Hello there. I'm Tim Cookson, Medicolegal consultant with Medical Protection. Welcome to our very first series of podcasts from MPS, created specifically for clinicians in Aotearoa, New Zealand. Today's topic is Complaints 101, and I'm lucky to be joined today by Dr. Lucy Gibberd and Dr. Sam King.
Hi, Tim.
Hey, Tim.
How you doing? So look, today we'll go right back to basics on how to respond to a complaint that comes directly to your organisation, whether this is a GP practice, a hospital, specialist private rooms, or any other health provider. This is not about complaints that come via the HDC or via the advocacy service, which we will deal with in later podcasts. So we've got an illustrative case, and although it relates to primary care, the principles apply to basically any health provider, whether you're working in private or in public hospitals. If you are in a public hospital, the nuts and bolts will usually be sorted by someone with a title such as Consumer Liaison Coordinator. But this is not always done correctly. So doctors working within hospitals may want to refresh their memories on how things ought to be done. So on that topic, Sam and Lucy, what are the common things that we see with complaints that get directed to hospitals and how they're managed?
Yeah, Tim, I think it's really important that each clinician who's been involved in the care of the patient has been made aware of the complaint and has been given an opportunity to respond. And as we know, this doesn't always happen, believe it or not. So if you hear of a complaint that's come from the family about a particular patient that you were involved in, be proactive and ask about whether any of your care has been mentioned. And often, particularly for junior doctors, sometimes the senior doctors will say to them, don't worry, I'll deal with it, which is very kind of the SMOs to do that. And I think that's really appropriate. But I do think it's important that regardless of your seniority, it's important to have the opportunity to see at least what has been written and to give approval to it.
Yeah, and I think another thing there is that often goes to the head of department rather than the clinicians who are actually involved. So it's important that if you are a head of department and you're asked to respond to a complaint, that you do look at who has actually been named in that complaint or the clinicians that were involved in that complaint and make sure that you at least ask them, their opinion on what happened and give them the chance to respond.
And I think that also goes for the complaints officers are often managerial staff and often they're non-clinical. And it's very difficult for a non-clinician to respond to a clinical complaint. And so it's important that you speak to that complaints officer and say, hey, if anything comes up with my name on it, please contact me. I'm very keen to be involved.
Yeah, and I think the other major issue with hospital complaints often is about timeliness, that they often seem to come in and sit on someone's desk for quite a time, and then the clinician actually gets given it maybe a day or two before the response is due, and that can cause some really significant problems. So I think it is important if you're working in a hospital or an environment where you're not in control of complaints coming in, that you do contact those people in charge and say, look, if you do get a complaint, please make sure you tell us quickly, because it takes some time to actually write a response, go through the notes. And if you're only given a couple of days, it can become a very stressful situation.
And the other thing in hospitals is often there are a number of people involved. So it's actually going to take quite some time anyway to coordinate all those responses. And one of the things, of course, that complainants really don't like is when they send in a complaint and it falls into a black hole and they don't hear anything because it's circulating around and around inside the black hole and nothing's coming out again. So that's the other thing, is to keep in touch with the complainant. If there is going to be a delay in responding, then whoever's coordinating that response has a responsibility to keep in touch with the complainant and just let them know, we're still working on it, don't despair.
Well, if you don't do that, of course, they're more likely to escalate it to the HDC, which nobody wants, really. I think too, for serious matters in the hospitals, the DHB might actually run a parallel process. So they will answer the complaint, but they may also start an internal investigation, or in very serious cases, an external investigation when they bring in an external expert to review the case. And it's possible that it could be a mandatory, what we call a SAC 1 or SAC 2 report to the Health Quality Safety Commission. And the SAC rating stands for Severity Assessment Code rating, which you can look up on the QSC website. So be aware of the parallel processes that might be running in your DHB for any serious adverse outcomes. And as part of that, they often run interviews, don't they, of the individual clinicians. And I've spoken to so many members where they say, oh yeah, they just asked me if I could just pop in and have a chat for 5 minutes about what happened in a case. And the clinician may not have even realised there was a problem. And because they want to cooperate, they pop in and have a chat in inverted commas. But I think for our listeners, remember that there is no thing as an informal chat, that it's far better to be well prepared ahead of time. And so the best thing to do is to delay the meeting and say, look, very happy to meet with you. How about we do it at the end of next week? In the meantime, I'm going to have a look at the notes and find out what went on and call my indemnifier. So just remember that.
Yeah, and I think the other thing to remember with hospitals is that the best interests of the clinicians and the patient and the DHB may not always align. And so I think doctors often think that, or other clinicians think that the DHB are going to actually have their best interests at heart and are going to be helping them with the response. And so they may think, I don't need to contact my indemnifier because the hospital lawyers will be looking at it. Whereas in fact, the DHB lawyers will be looking at it from the point of view of the DHB's risk, and that actually it's really important that the clinicians do contact their indemnifier, who's going to look at it with a different lens, because we're going to be looking at it with the lens of the risk to the individual clinician.
Mm. Look, Sam, those are really important points about those inquiries. And I think that's just given us an idea for another podcast, really, because there's actually so much that we could do on that we could come back and expand on that topic. So look, let's move on to the composite case. And this is made up from a number so that it's non-identifiable. So this is a Dr. Jones who works in a 4 GP practice in a medium-sized rural town. He sees a patient who's been with the practice for some time, but he has not met her before. Jane, the patient, is 18 and keeps generally good health, apart from the odd fungal infection in various bits of her system, and she gets some hay fever as well. She arrives early for her appointment, and she comes in looking a bit tense. She tells Dr. Jones that she's had troubling symptoms ever since her COVID vaccination. Tingling in her lower leg, intermittent abdominal pains, tiredness, and irregular periods. She also wants a repeat of her usual medication. She tells Dr. Jones that she did not want to have the vaccine but was obliged to do it for her work, and she's still angry about it as it's had a big impact on her. Dr. Jones, who's pretty aware of these things, immediately picks up that this is not going to be an easy consultation and spends some time exploring the symptoms and starts to discuss possible investigations and points out that some of these, such as an abdominal ultrasound, would need to be done in private, for which there is a fee. Jane gets very upset about this and says she just wants it fixed. Also, she wants to know if her warts can be treated and starts talking about her back pain, which comes and goes. Dr. Jones tries to focus on the original issue, but Jane now wants to discuss her chronic anxiety and depressed mood. As you will have guessed, by this time the 15 minutes allocated have well and truly passed, and Dr. Jones advises that Jane will need to make another appointment to discuss her mood, and this seems to annoy Jane even more. She leaves, clearly not happy. Later that afternoon, Dr. Jones gets a call from Jane's mother, angry that Jane's issue relating to her vaccination has not been sorted in the appointment and complaining that Dr. Jones has not done his job properly and wanting an explanation. She is a little surprised to hear that Jane actually had a number of concerns that she presented at the appointment. So, Lucy and Sam, what are the issues that you can see arising out of this situation so far?
Well, the first thing is obviously that it's not the patient here who's complaining. It's the patient's mother who wasn't actually there. And this does happen quite a lot, that someone who wasn't in the consultation complains about a consultation. And they may have heard one side of what happened from the patient and may only have half the information. And then you have to think, well, Jane's 18, I think we said, didn't we?
18, yeah.
And so her mother doesn't actually have a right to her medical information, which does make it very difficult to talk to her mother because obviously the doctor has got to be very careful about what is actually said and making sure that she does have the patient's consent to release any information that she does to the mother.
I was thinking that, isn't that just very typical of a lot of GP consultations where you've got the patient who brings their list in and they don't necessarily tell you the entire list when they actually sit down. And I think particularly for younger GPs, it's probably a prevention is better than cure. And the better we get at managing patient expectations and controlling the list, the less likely we are to run into complaints.
Well, is this a complaint, Sam? I mean, the mother just rung up. She's expressed her dissatisfaction. But, do you really call this a complaint?
I think I would. Anyone who's expressing an opinion that is not positive, and she's taken the time to do that, I think you would take as a verbal complaint. She must have been incensed enough from what the daughter had said to pick up the phone.
Yeah, and Dr. Jones certainly interpreted it as a complaint and wasn't entirely surprised to have received it. So he advises Jane's mother that he will lodge her verbal complaint as an official complaint and that she'll hear back from the practice complaints officer about this. Jane's mother responds by saying, well, they'd better be quick. If she hasn't had a full apology and refund within the next 3 days, she's going to complain further. What are the issues now, team?
Yeah, 3 days is quite quick. And in fact, that is beyond what the Code of Rights actually says. We generally say you need to acknowledge a complaint within 5 days. And then hopefully within 10 days after that, you've actually given a response or at least told the patient when a response might be coming. So even though Jane's mother says 3 days, that's not what the code says. However, they'd probably be best to actually send something within those 3 days just to show that they are taking it seriously. But then the question is what you're going to send as well, because obviously the mother is not the patient and we've got the issue of consent here.
Yeah, you'd want to clear that up first, wouldn't you? You'd want confirmation that the daughter is happy for the practice to respond to the mother, or you respond directly to the daughter, and that would seem to make a lot more sense, to respond directly to the daughter.
Along the lines of, we've had a complaint from your mother, but we're responding to you, because that way you're not going to have any risk of breaching her privacy.
Mm. I think within the 3 day, and we do get calls, don't we, from practices that say, they've demanded that they hear from us, by the end of business tomorrow, and they've got a lawyer involved, and so please can you do this, get onto this case today. And I think that so long as you give a solid acknowledgement, apologising for the distress they might feel, or sorry that your care didn't meet their expectations, or whatever you can apologise for, that's what's important in that first letter. And then you can explain, that it does take time for an investigation to take place, and therefore, they will hear from you in 10 days or whatever it happens to be.
And that's the key message to get across at that stage, isn't it? Is that you are taking the issue seriously. If patients at that very early stage feel as though their complaint's not being taken seriously, then that's an escalation about to happen, basically. So I agree. In terms of responding then with that initial acknowledgement, what's the best way of doing that? What are the options that the practice manager or complaints officer might take?
I think it depends on the complainant. If you've got a good relationship, know them well, then you might want to pick up the phone and have a conversation. And at other times, if you aren't confident about that relationship, it can be better to put it in writing. And if you think about it, you've got an emotional complainant on the other side, and whatever you say on the phone, the patient or the family might not even really register what you're saying and have no real proper recall of what you're saying. So it's always good to follow up anyway with something written, giving that solid acknowledgement with a really nice tone. And as you know, we often see letters being drafted with probably what I would consider to be a slightly formal or cold tone, or slightly harsh, and that's not the approach that tends to de-escalate matters. So tone is really important, but you can put all of that into an initial acknowledgement letter, and that might go a long way to helping to resolve the problem.
Yeah, and I think it's good not to have a saying we're going to respond by this date, because you can just about guarantee something might go wrong between that now and then. So I often think if you're going to say, thank you for your complaint, we're looking into it, we're going to respond in the next 2 weeks, or we'll let you know if it's going to take us longer than that, so that you've kind of given yourself a bit of an out, just in case it does take longer than you expect with staff sickness and other things that happen along the way.
And we've certainly had cases. I had one recently where the complaints officer was stuck in Europe because she got COVID. And so that made coordinating the complaint response rather tricky for her. So in this case, the complaints officer actually meets with Dr. Jones and they review the notes together and they start to prepare a response to the verbal complaint. Jane, talking of consent, gives her consent for her mother to receive the information and for the complaint, including release of confidential information, to go to the mother. Talking of the consent then, how should this be recorded? Is this a written consent required from the daughter, or can just the verbal consent be recorded? What do you reckon?
I think it's all right if the patient rings up and says, look, I'm consenting for my mother to receive a response to her concerns. As long as you've documented that very well, the time and the date and who she spoke to and what exactly she's consented to, and that it's been made clear to her that that is going to involve the release of her health information to her mother, and that, and giving her the option that, do you want to see a copy of what we're going to send to your mother first? Because obviously as a teenager, she may not actually think necessarily about the consequences of what might be in that response. And we do want to make sure that she's actually knows what she's consenting to and then document very well that we've explained that.
And certainly we've had situations where one family member has complained on behalf of another, but when the actual patient has been contacted, they say, well, I haven't got any complaints and I don't want anything to be sent. So we do have to do that process carefully. But I think on the other side, making the process too formal by demanding a written consent and all that kind of stuff kind of sort of escalates it.
It looks obstructive, doesn't it?
Exactly.
It looks like you're trying not to actually answer. So I think you've got to be careful with the tone, as Sam says, that you may keep the tone. Yeah,
it looks obstructive and defensive at the same time, and neither of them are great things to be transmitting to the person who's complained.
It's probably a good time to just mention that complaints shouldn't be recorded in the clinical notes, because we often see that, don't we, when we receive the clinical notes, that there it is, all the MPS advice and the details of the complaint. It's far better to put that into a management file, simply because it's not about the provision of healthcare and it shouldn't follow the patient around wherever they go. The complaints process is completely separate to that. So any advice that you receive and any details of the complaint should really be held in a separate management file, presumably with the practice manager.
Do you make any reference to the complaint at all in the clinical notes?
I think that if the complaint is providing additional clinical information, that you might want to put that into the clinical notes. But I don't think it's necessary. I think the answer, I would say, is usually not, but it depends. Because there are some complaint letters, as we know, that are asking clinical questions as well. And so I usually advise our members to separate that out. Any clinical questions should be dealt with in a consultation, and any complaint should be processed completely separately from that.
Yeah, and I think that's the default position is no, but look, we're happy to discuss that kind of thing, and there are always exceptions to the rules. So the team get onto it pretty promptly. The draft response is prepared well within the 10 working days, though Dr. Jones, it has to be said, is not happy with the time and effort this is taking when he'd actually felt he'd done as well as he could in quite a difficult consultation. So, team, can I get you to sort of outline kind of the format that we would put these responses? Lucy, would you like to start off by how you would how the response might look?
Okay, so look, generally, again, tone is important. So we'd like to start with an acknowledgement of the complaint and say, thank you for letting us know of your concerns. We'd often put an apology in there if there's an apology that is appropriate. We don't want to say sorry for things that aren't our fault, but it's absolutely appropriate to put a sorry in there if it's appropriate. Then we'd normally get people to go through the story of what's happened. I saw you on this date. This is what we discussed. This is what happened. And so that you've done a kind of a timeline of what's actually been involved in their care. And then after you've finished your timeline, you'd normally go on to address the specific concerns that have been raised in the complaint and try and address each complaint separately, because often there are several issues. Often it might be about manner and what happened, and then the cost and a whole pile of things. So often I say go through the complaint letter, highlight or underline the bits that are actually the complaints and make sure you've addressed all of them. And then often we want to finish with a reflection of, that the doctor's thought about it or the clinician's thought about the complaint and how it might influence their practice in the future and systems that they might change as a result to try and make things better for patients in the future and how it might improve their practice. And then the very end is often saying, look, I hope this has resolved your complaint. If not, do let me know. And sometimes we offer a meeting, not always, but sometimes it's nice to keep the door open and say, look, if you're still worried, let us know. We're happy to answer further questions or have a meeting if that would be preferable for you.
Yeah, I think some of our members too, when they respond, are a bit light on the clinical detail that they provide in response to a complaint. And I think if a patient has written you a 3-page complaint and you send them half a page response, they might feel like you haven't taken it seriously. And so I would generally recommend that you do go through the consultation or consultations in some level of detail to explain exactly what went on in there. Not in so much detail as you would to maybe another doctor, but with enough detail to say, well, this is the consultation as I recall it and is in my notes. And that demonstrates to the patient, oh, yeah, that's right, that's what happened. Oh, yes, and then we did that. So it's a reminder to the patient of what had happened. But also it's like, oh, this doctor's taken me seriously because actually they've looked at all these parts of the consultation. And I think it's important too that doctors remember not to do a cut and paste of notes in any forum. So definitely not to the complainant and not to the HDC or the medical council because we're all GPs here in the room, Lucy, Tim and I, and when we read GP notes, we generally understand them. They have to be pretty bad for us not to understand them, but the general people out there, including other doctors, don't understand the shorthand that we use necessarily. And so writing in whole sentences as a narrative is actually a really good way to go.
I'm very upset, Sam. My notes were always excellent. I don't know how you could possibly imagine that they wouldn't be suitable for Yes, absolutely. And we need to also remember that unless patients have got access to their notes, say through a patient portal or something like that, they will have forgotten most of what happened in the consultation. And although we can't record everything that happened, we certainly record the important medical stuff. And there's often information there that patients have completely misinterpreted or forgotten. So, yeah, a good reminder about what happened during the consultation, I think, goes a long way to resetting the expectations, when someone's upset about something.
Yeah, I like to tell our members, let the facts speak for themselves. Because that's all you have to do is set out the facts, and often that will answer a lot of the questions. So you don't have to argue the toss with the patient about every little point. You just say, well, these are the facts as far as I know them to be, and often that's enough.
Often as part of the complaint, there is a bit about manner as well, the doctor's manner, because clearly to actually have made a complaint, the patient is upset. And so often we'll find, as well as the clinical aspects that need to be addressed, you actually do need to also say something about manner. And that is often that the patient feels that the doctor was disrespectful or rude or brushed off their concerns. And those things are very hard to answer because clearly the doctor doesn't feel that, in most cases, doesn't feel that that's how they behaved. Occasionally they may have done, but generally that's not how they've behaved. So look, when you're answering those things, I think all you can do is say sorry. Sorry if I came across as being brushing off your concerns. As you can see from my notes, actually I took them seriously and I've written them all down. So I think it's always a little bit difficult that aspect of the complaint, because often the clinician says, well, I wasn't rude and I didn't dismiss them. But actually you still have to acknowledge that part of the complaint and address it in some way.
Yeah, and look, we don't intend to be rude or dismissive when we're in the situation. So, we can certainly say that was certainly not my intention.
Not my intention.
That you would feel like that, absolutely. Where does sort of advising the complainants about the HDC come in all of this? Because in the code it says that complainants must be aware of their rights to complain to various authorities. When's a good time to do that in this complaint process?
My usual advice is to try and deal with the complaint locally first. And if you can't resolve it, then advise them of the free advocacy service that they can avail themselves of, and then the HDC. As we know, the HDC have had a 25% increase in complaints over this past year, and it looks like the trend is continuing. They're just getting an increasing number of complaints. They certainly don't want to be looking at low-level complaints, and we're aware that the Commissioner is very keen for early resolution, and the best way to resolve something is to deal with it locally. So that's what I would do. Clearly, if the patients are extremely angry, and you're not really getting anywhere, you don't feel like you're connecting with that particular complainant, I would certainly notify them of their options at that point early on.
Yeah, I think it's fine to just say, come get back to me if you're not happy, and we'll have a meeting, or I'll answer further questions. And I don't think you have to talk about the HDC at that point. I think if you are finding it's a struggle and you feel like you're not able to address their concerns, the right step then is to actually tell them about the advocacy service, because that's another. It's not as it's more like to resolve concerns quicker than the HDC, which I think we can all agree is a better thing for the patients and for the clinicians. So I think letting them know about the advocacy service is the way to go, and definitely not putting the HDC leaflet in with your response letter, I think, because a lot of practices I know have that as part of their complaints process. And I think that and on the whole, that's not really necessary.
It gives the wrong message, doesn't it? That we can't resolve this and you can go to the HDC and get them to resolve it. Whereas I think if we can really focus on, let's try and work this out between ourselves, then take other steps if that's clearly not going to happen, as you say.
The advocates are actually very good.
Yeah.
I've noticed over the recent years that they've really improved in how they help to resolve matters, and especially when you've got complainants who are not health literate, who perhaps aren't even sure what they're complaining about, and have a whole mess, really, of things that they want to talk about. The advocates are very good at sorting through that and putting it in bullet points so that the clinicians are able to understand the complaint.
And we'll probably talk about that more in our podcast on advocates and HDC. That was the HDC. When should a practice like this talk to MPS?
Right at the start, Tim. Don't wait. Look, we've got a service where you can ring us and talk to our case managers or one of our advisors, and often just talking it through is actually that is helpful, but also we're happy to look at those responses as well. And I think, obviously this is our area of expertise. This is what we do all day. So I think that we can really help often get that initial response into a really good, into a good tone, and to make sure it's addressed the concerns. And I think that's probably the quickest way to get things solved. So yes, call us straight away.
That said, though, I mean, we of course don't know how many complaints are dealt with locally that never contact us, and I'm sure there are plenty, because I'm aware of a large number of practice managers who are very good at managing complaints. I think it's more when you have an inexperienced practice manager, you might want to get some help. But the really experienced ones often don't need to call us unless it's things are really difficult.
Yeah, and I think it's those red flags, isn't it, that say, yes, it's really important to ring MPS. So if you think, this is going to go further, or this was a significant mistake, a significant error, and therefore I'm vulnerable, or I'm just not confident that we're going to be able to manage this particular complainant very well, then those are certainly indications. But if in doubt, give us a call. We'd much rather know about it earlier rather than later. It's really hard to undo what's already been said, isn't it? So while MPS is reviewing this draft, Dr. Jones receives a letter from the HDC. Jane has laid a complaint with the HDC and has a long list of issues, including that they hadn't received a response to her mother's complaint. So now we've got the complaint that you're trying to deal with directly to the complainant, but you've also got the HDC writing to you. What do? Do you answer both? One but not the other? Which takes precedence? Lucy, your thoughts?
Yes, it's tricky, this one. And in general, once the HDC is involved, we actually suggest that you respond to the HDC. Having said that, you've already sent an acknowledgement letter saying that you're going to respond within 10 days to the mother's complaint. So you don't want to renege on that. So it's possible that what you could say is respond to the mother saying, look, we've now received complaint from the HDC, therefore we're going to send our response there. Or you could just choose to send that response to the mother still. But actually, if there are more issues in that HDC complaint, you really do want to make sure you've got a really good response to the HDC. So that's a bit of a tricky one, Tim.
Yeah, I don't think anyone's going to be criticised, though, for writing back to the complainant and saying, we've now received the complaint from the HDC, we'll be responding to the HDC now, and you'll be involved in that process through them. I don't think the HDC would ever be critical of us for not responding directly to the complainant at the same time as we respond to the HDC.
It's interesting. I was talking to a practice manager just very recently, and she said that a patient had come into the practice very grumpy, angry, and it was dealt with by the practice manager quite satisfactorily. She contacted the complainant and thought that it had resolved, and then 2 or 3 weeks later the HDC letter comes, and so when the practice manager asked me, what on earth do we do now? And what I'd said to her was that in actual fact the complainant might have sent the HDC complaint off at the same time as complaining to the practice, and to speak to the complainant in this situation and say, look, we've got this HDC letter, do you feel like it's been resolved, or would you like us to respond to the HDC? And as it's turned out, the patient was quite happy and it just fell away and didn't need to respond to the HDC at all.
And certainly a proportion of complaints are withdrawn when you look on the HDC website on their annual report.
And I do think with email complaints, people often do just CC the HDC. And so that actually...
And the MP.
And the MP and the Prime Minister. But actually, if you've already responded to it because you've received it, I think if you then receive the HDC letter, the other option is to write back to the HDC saying, look, I've already responded to the patient. This is the response we've sent. We believe it's resolved now. And actually, we've already done this. So, and I think you can often see from the dates, because the HDC process can be quite slow, so it's entirely possible that the practice has fully resolved it before the HDC has even sent their letter out.
And so look, the final issue here with this complaint was that it's actually quite personal about Dr. Jones and about how bad he is, and comments about how he needs to be struck off, etc., etc. This is pretty nasty stuff from Jane to an authority. Can the practice disenroll Jane on the basis that she's made a nasty and unfounded complaint to the practice?
No.
No.
As much as you might want to.
Much as you might want to. Look, it's that right 10, that sneaky right 10. Patients have the right to complain. And if essentially they're disenrolled as a result of a complaint, that's essentially removing their right to complain. So actually, if it's because of the complaint, no, I don't think it's appropriate.
I think generally speaking, patients who are really unhappy with a specific clinician will not go back to that clinician. They will vote with their feet. But if the patient does want to come back and there's a tension in that relationship and the doctor's feeling very nervous and uncertain and doesn't feel like they're going to be able to act in the patient's best interest, it's actually worth a conversation with the patient. And I think it depends on how strong the feelings are, obviously, on the doctor's side or the clinician's side. But I think it's worth having the conversation, absolutely you're right to complain. No problem with that. We're responding to that. But it just seems to have raised an issue of trust. And as we all know, trust is the basis of the therapeutic relationship. So you need to reestablish that there is trust in that relationship. Otherwise, it's very difficult to continue.
And it's pretty hard when you've had a nasty letter really getting at your integrity as a doctor to then treat someone in an unbiased way. And I think if Dr. Jones said, look, I don't think I can personally see this person ever again because of the nature of what she said in the complaint letter, I'll make sure that the practice provides someone who can see her, but I'm not going to do it anymore. I think we would defend Dr. Jones's decision on that basis that really he couldn't offer her good care because of what had been said.
And that happens in the DHBs as well, doesn't it, where the patient is passed on to a different clinician.
But I think it's important that you don't, in your complaint response, say, and now I'm not going to be your doctor anymore. Because I think that clearly breaches Right 10. And I think you have to be really clear that actually that the complaint is not the reason why you're asking a patient to leave your practice. And I think it's, as Sam says, if you can indicate that there's been a breakdown in the relationship and a lack of trust, then actually, and that's the reason, not the complaint, then But that can be quite tricky to do in the middle of responding to a complaint. So I think often we suggest that you deal with the response, deal with the complaint, and then come back and talk to the patient about the trust issue as a separate process so that the two don't get kind of entangled, and it could look like the complaint is the reason they've been asked to leave.
Sometimes, and I'm just thinking of an issue that arose this week, I'd been assisting a couple of doctors with a complaint, and when we'd sent the responses off, the doctor then got back to me and she said, look, do I have to continue seeing this patient because of the complaint? And my first response was, well, yes, you do. And she said, well, but he was really angry when I last saw him, and he deliberately came up close to me and coughed in my face and then said, what, are you afraid of COVID? And my response to the doctor was, well, there's been a successful charge of assault from a man who coughed deliberately at people, and that I would say that's grounds for instant disenrolment, and we would support her if they did that.
It's all about context, isn't it?
Yeah, absolutely.
In some situations, you can disenroll someone on the spot or, in a very short period of time. But I guess if you're thinking about that, and you're not certain, it's best to call us and talk through the issues.
That's an unusual scenario, and very rare that we would suggest instant disenrolment. So, in summary then, complaints can either be verbal or in writing, and they carry equal weight no matter how they're expressed. When a complaint is received, there needs to be an acknowledgement sent within 5 working days, and then under the code, you have either a further 10 working days from the acknowledgement date to either investigate and provide a full response or to advise when this response will be ready. So the 10 working days, it's a guide, but so long as you communicate, if that's not going to be possible, that's absolutely fine under the code. As we discussed, most organisations manage complaints really well, and we only see a small proportion of local complaints, and of course the HDC only sees a tiny proportion of the total complaints that are out there. But if there are threats to take a complaint further, there's been a significant error, and there's any other reason that you're concerned about a complaint, contact us early. Generally, we aim to avoid an escalation to the HDC if that's at all possible. But actually, on occasions, it may be that the HDC is easier to deal with than the complainant. And if that looks like being the best course of action, we may well suggest that route. Complaints can vary from being helpful because the complainant has identified a scenario that actually needs to be fixed, and they've actually done you a favour by pointing that out and ensuring that further problems don't occur. Or they can be quite harmful, as Dr. Jones found, with a very personal kind of impact of the things that were said. And if you have been significantly affected by a complaint, MPS and MAS offer psychological assistance for our members, provided by clinical psychologists with a system that was set up precisely for this reason. So thank you very much, Lucy and Sam, for sharing your knowledge and experience today. And thank you all for listening to this podcast, which I hope you have found helpful. We look forward to catching up with you in our next podcast. And if you like medical protection podcasts, please subscribe and leave a review. Thank you.
Thanks, Jim.
Thanks, Tim.